This Artificial Intelligence and Equality podcast is hosted by Carnegie Council Senior Fellow Wendell Wallach. Together with Anya Casperson and an international advisory board, they direct the Carnegie Artificial Intelligence and Equality Initiative, AIEI, which seeks to understand the innumerable ways in which AI impacts equality and international affairs. This episode features Dr. Joseph Fins being interviewed by Wendell Wallach. It was recorded on November 29th, 2022.
Welcome, everyone. In our series of esteemed people that we're getting the opportunity to podcast, today we are going to talk with Dr. Joseph Fins. And we're going to turn to neuroethics. Neuroethics is not a subject that has come up yet in our AI and Equality podcast, but I think most of you understand by now that AI is an amplifier of research for many emerging technologies, including the neurosciences, and it not only amplifies research, but it is actually being integrated into a number of the activities surrounding neuroscience. This is going to be the first of what I expect to be a number of podcasts we will do on neuroethics this year. We're going to follow with a podcast with Nita Farahani, who is the past president of the International Neuroethics Society, when her new book, The Battle for Your Brain, Defending the Right to Think Freely in the Age of Neurotechnologies, comes out sometime this winter. Today, we're going to be talking with Dr. Joseph Fins, who is the sitting president of the International Neuroethics Society. He is the chief of the Division of Medical Ethics at Weill Cornell Medical College, where he serves as the E. William Davis Jr., MD, Professor of Medical Ethics and Professor of Medicine. Some of you may be interested that way back when he was appointed by President Bill Clinton to the White House Commission on Complementary and Alternative Medicine Policy. Among his many honors is that he is a member of the National Academy of Medicine, of the National Academy of Sciences, and he is a fellow of the American Academy of Arts and Science. Joe has written two books. One is A Palliative Ethics of Care, Clinical Wisdom at Life's End, and more recently, Rights Come to Mind, Brain Injury, Ethics, and the Struggle for Consciousness, which was published in 2015 by Cambridge University Press. We're going to talk quite a bit about the latter book, but before we get to the research Joe has done leading up to that book, I just want us to touch a little bit on where we are in neuroscience and neuroethics, because many of you are confronted with science fiction like Minority Report or sensational articles about a particular neuron firing when someone's name has been mentioned. And it's very hard to know what of these are real, what is likely to occur in the near future, which I mean the next 5 to 10 years, and what is truly fanciful at this stage of the game. So Joe, can you just help us with that a little bit?
Sure, Wendell. First of all, thank you so much for having me. It's really a delight to be here with the Carnegie Council and to participate in this wonderful series of podcasts. So, I love science fiction, but we don't need to invoke science fiction to make neuroethics interesting. We just had our meeting of the International Neuroethics Society in Montreal, and our theme was bringing neuroethics to life through the life cycle. And it was really a response to the sort of often hyperbolic, fanciful science fiction-y kind of, predicates that often, generate, discussions in neuroethics circles. It sort of starts like this. A three-headed cyborg goes into a bar and has liminal capacity and wants a deep brain stimulator. We don't, that's kind of like they're hypotheticals and they don't adhere to reality. So what we tried to do at this meeting was have a counter meeting and look at the concrete challenges through the life cycle in clinical neuroethics and in research neuroethics. So, I think, the problem with these hypotheticals about, devices that can read your mind is that it delegitimates, important applications of neurotechnologies that are important to understanding how the brain works and actually caring for real people with neuropsychiatric problems. And I would say neuroethics is not just the ethics of neurology, but it's also the ethics of all the things that happen in the brain, including psychiatric illness. So the divide between neurology and psychiatry is collapsing as we think about the brain. These two specialties, which began in the early part of the century as kind of more closely linked, are coming back and converging upon each other, in part because of the evolution of the neurotechnologies that show that who we are as people and our biology are inextricably linked. So I think, I mean, there really are two schools. There are the fearing doom, crying Chicken Little kind of perspective in neuroethics, and then there are people like me who are doctors who see the suffering and want to respond to it and see the tools that are being developed as incredibly instrumental and helpful in unwinding what Wilder Penfield, the great neurosurgeon and the founder of the Montreal Neuroethics Institute, neuroscience, let me do that again. Wilder Penfield, who was the great neurosurgeon and the founder of the Montreal Neurologic Institute, and the mapper of the homunculus in the brain, called The Mystery of the Mind. And we're getting closer to understanding it, but it's like an onion. The more you peel back, the more there is to peel. And then you start crying and you have to start all over again. But I'm in this former school, this kind of grounded in reality neuroethics. And I'm concerned, to be quite honest, about some of my neuroethics colleagues that sometimes, speculate about things we should be fearful about because they can have a chilling effect on research and practice.
So let me ask you about one particular area that a lot of people bring up, which is this notion of mind reading, that we're really getting toward technologies that are actually going to be able to read your mind and therefore invade your privacy. Give us a sense of where we are and where we are not as far as the development of such technologies.
I mean, I think we're not there yet. It's kind of like modern phrenology at this point. We can say words to you. And show that certain areas of the brain activate. And, areas that pertain to the speech act, but we can't decipher necessarily what you're thinking or what you're saying, what your thoughts are. But there is a whole cottage industry of the importance of protecting cognitive liberty. We can't do that. So does that mean it won't happen? Not necessarily, but it's not imminent. And so I think, having said that, it's very important to have what's called anticipatory governance. We need to think about future developments so that we're prepared to respond to them. But this is not an immediate threat.
There has been this concept about positive and negative rights, which gets applied to this question of what kind of neuro rights. I don't think we want to go into this into great detail now, because this will be a core subject with Nita later in the winter. But can you kind of clarify? Positive and negative rights.
Yeah, I mean, I introduced this recently in an article. I think I was the first to do this in the context of the Chilean constitutional reform. So they had a constitutional plebiscite in Chile in September, which did not pass. But one of the over 400 elements was about neuro rights. And my critique of that was that it was really centered on all the things you can't do, the negative rights. You can't intrude on people's privacy. I mean, the greater threat to your neural privacy is somebody looking at your phone and your emails and your texts and all that, because that is a repository of your thoughts. It's actually the phenotype of the genotype of what you're thinking. But my concern was that in articulating all the negative things you could not do that could violate things like cognitive liberty, you can't intrude on the brain would preclude things like deep brain stimulation, even neuroimaging, because it does reveal information about your what areas of the brain that are being activated. And my concern was that in focusing on negative rights, they were not thinking at all about positive rights. That is, the right to be able to communicate if you are locked in, or if you have we'll talk more about these various brain states, but the ability to get out of your head and integrate yourself into society in a way that's consistent with other international law, like disability law, like the Americans with Disabilities Act or the UN Convention on the Rights of People with Disabilities talks about the right to community. But in a sense, if you can't do certain negative things, like I can't fix your gallbladder if I don't operate on you. So I need to violate your bodily space to take out your inflamed gallbladder. That doesn't mean that I'm committing a tort or I'm injuring you. I'm doing something in the interest of healing and helping. And I think the same, dichotomy needs to exist when we talk about neuro rights. And just to sum up, negative and positive rights need to be in a kind of homeostasis with each other. They need to be balanced.
So before we get into various mental states that need therapeutic attention, let's stay back with this mind reading question for one more moment.
Mm-hmm.
So all of the sensational articles we're seeing about, let's say, a particular neuron responding or areas of synapses firing are when there's neuroimaging taking place. And for all practical purposes, these are really one-off examples. And we have nothing short of neuroimaging devices that can help us even see that far into the brain. That's at least my understanding. But are you aware of any technologies that might be utilizable to see the neural responses of people short of neuroimaging technologies that could be used without people being aware of it? Or,
well, there's
imagine tactile stimulation if you had that built into your mouse, and that could be perceived. But we don't really have anything that really gets into detail in understanding what's going on in your mind beyond what can be deduced by your social media record, for example.
Right. So I think that neuroimaging, functional neuroimaging, right? Let's just describe how it works. It's not even a contemporaneous activity. It's a function of glucose extraction from the blood,
right,
which is necessary for the neurons to power themselves up. So a certain the motor cortex is doing some work about thinking about moving my arm here. Milliseconds after the electrons fire and the area gets activated, there's going to be an extraction of glucose from the blood. And if you have tagged glucose, you see that activation, in that area. Okay. It doesn't mean that I'm thinking of playing tennis or swimming or just, it's just that area has been activated. EEG is more, contemporaneous, but it's a bunch of squiggly lines. And that can be localized, but it doesn't have content, per se, as semantic content. The one area that is interesting is use of brain-computer interfaces, where people who are locked in, for example, can have a thought about moving a cursor, for example, in their head, and direct a mouse that's on a screen to spell out words, for example. But it's with the cooperation. It's volitional. It's with the cooperation of the individual. It's not like somebody is reading their thoughts. Somebody has to actively engage, and there's got to be an algorithm that is set up to translate these activities with the brain computer interface. So it's not a crypto thing. It requires the cooperation of the individual.
Right. And I think that's what, hopefully our listeners are understanding here. These questions about you being mentally violated, they really are not viable in any way, shape, or form with present day technologies. But as we move toward interfaces, either internal or even on the surface, such as virtual reality devices and so forth, where there is a brain-computer interface, then those neuroethical issues that you hear about in science fiction, then those will start to become real, and we need to get into those in greater depth, but we aren't quite there yet.
Or not, or they may not become real, right? I mean, it may not evolve, or it may, there may be ways of regulating it so it's, it's obviated as a concern. I just think that, talking about hypotheticals is may attract, interest, but it may not be the best way to think through a problem, because it may have consequences in real time for real people.
Good. Well, again, for those of you who find this part fascinating, tune in, because we will be coming back to it in February or March. But let's move more toward the area where you have done seminal research, which is to work with people who, well, we have a lot of different phrases, don't we? Locked in, brain dead, minimally conscious. I think we all hear these phrases quite often, and they're a little mysterious because there's real concern whether, when we are dealing with people who seem to be not conscious at all or minimally conscious, what becomes appropriate to do with them, what is inappropriate to do, what kind of care they should get, whether even turning off their life support is valid or not. And it seems to be an area that that you're doing some of the seminal research in, but we probably don't know as much as we would like to. But let's start with you just defining what these
Right. That's a good idea. So let me just take you through the life cycle of a brain injury, as it were, a biography of a brain injury. How about that? So we're not talking about concussions and things like that. We're talking about, you have a brain injury where you actually lose consciousness. And that can go in several different ways. You could have a syncopal event where you lose consciousness briefly, you pass out, you wake up. We're not talking about that. We're talking about somebody who enters into what's called a coma, all right? And a coma is an eyes closed state of unconsciousness that is self-limited in time. It lasts up to a couple of weeks, unless it's like medically induced, in which case it can be prolonged. But generally, you either recover from a coma, you wake up, like anesthesia would be an example of that. Or if I spoke too long, I presumably could put you into a coma and hopefully you'd wake up. but that's a joke for our listeners. Wendell is laughing. But so coma is self-limited, and it resolves in three ways. You wake up, you progress to brain death, which is whole brain death. So it's the death of the entire brain, including the brainstem, or you move into what's called the vegetative state. And the vegetative state is the isolated recovery of the brainstem, which is that part of the brain that's just above the spinal cord. And that part of the brain is responsible for sleep-wake cycles, propelling your heart along, your breathing and all that. And notably, what makes the vegetative state so confounding and challenging, unlike coma, it's an eyes open state of unresponsiveness. So the eyes are open, but no one is theoretically home. And that becomes very difficult for families, because usually the eyes are the windows on the soul. And if you open up your eyes, I think Shakespeare said that, if you open up your eyes and you're not aware, it's devastating. And if you read, probably the most famous vegetative person ever was Karen Ann Quinlan, about whom the right to die, case was established in 1976. But if you read Mrs. Quinlan's a memoir of the circumstance of what happened when Karen opened her eyes, there was great excitement. They called the nurses over, and then the devastation that sunk in when they realized that they were not seeing eyes, that it was just the recovery of her brainstem and not her higher cortical function. And of course, the vegetative state is important sociologically because it was linked to the right to die. And in the Supreme Court case in New Jersey Supreme Court a guy that Chief Justice Hughes said, it was a lack of her cognitive sapient state that became the moral warrant to allow her to die and have her ventilator removed. Now, this is important. When they removed her ventilator, she didn't die.
Right.
Why didn't she die? Because she wasn't brain dead. And the distinction between the vegetative state and brain death is that vegetative folks have an intact brainstem. And so long as the airway is protected, the brainstem will propel the ventilatory response. So in fact, when we do brain death testing, what we do is we take the people who are off the ventilator, the carbon dioxide levels go up, and usually that what we call hypercapnia or high carbon dioxide levels would prompt the breath. And if they don't breathe, they're brain dead. And if they breathe, they're in the vegetative state because they have an intact brainstem. Okay, so that's the vegetative state. Initially was called the persistent vegetative state, but now we have different modifiers for it. If the vegetative state, now current nomenclature, if it lasts for 3 months after a anoxic brain injury or a year after a car accident, traumatic brain injury, used to be called permanent, now it's called chronic vegetative state. We'll get back to that in a second. And then when people emerge out of the vegetative state, they move to a state called the minimally conscious state, which to me is the most interesting state of all. I mean, maybe there are other states of being that are more interesting, but academically, it's kind of captured my attention. And these are people who appear vegetative, okay, but they have episodic awareness of self, others, or the environment. They might, reach for a cup. They might say their names. They might look up when you walk into the room, but they do this episodically and intermittently. But they are conscious. But oftentimes they're not recognized as such. In fact, there have been studies that up to like 40% of people with traumatic brain injury in nursing homes who are thought to be vegetative, when carefully examined, are actually minimally conscious. So we're missing consciousness. Big deal, right? Because consciousness is who we are, right? We miss it 4 out of 10 times. So these are minimally conscious people, and their brains are completely different than vegetative patients. If you look at the circuitry, those minimally conscious brains are integrated. The vegetative brain is disintegrated, not that it's just kind of disintegrated, but it's not working as an integral entity. It's not communicating with itself. And we now know that the brain kind of communicates in a cortical thalamocortical tracts. There's circuits that are intact, and that's how it works. And the minimally conscious brain has these intact, widely distributed networks that can be the template for consciousness. But what happens here is really interesting. Without adequate arousal from the brainstem and without adequate stimulation, those pathways which are there are underactivated. So it's kind of like there was this great Spanish neurophysiologist named Jose Manuel Rodriguez Delgado, who I just wrote a paper about in the Neuroscientist. Long story short, he wrote this book to psychocivilize the brain society in 1969, and he had this great metaphor about the brain. He said it's kind of like an interstate highway. All right, but without the cars and the trucks and the business people, it's just a useless stretch of pavement. And the minimally conscious brain is like that interstate highway. It's there, unlike the vegetative brain, which is the highway's been destroyed. But the minimally conscious brain is there, but it's not activated. And a lot of the therapeutic initiatives have been to put commerce and trucks and people on the highway so it can activate itself. And that's the difference between the minimally conscious state and the vegetative state. And the reason that people in the minimally conscious state episodically appear aware or not is they get different amounts of arousal or sort of activation from the brainstem up into the cortex. And this means that you have to do a bedside exam like 5 times to get an adequate sample, because they wax and wane over time. And if you get them in their dips, they're going to look vegetative. You want to get them as they kind of crest into higher levels of function. And we give them credit for their highest level, their best grade counts, not their least lowest grade counting. And then after the minimally conscious state, we call them emerged. And these are people who are reliably communicating to responses. So if I say, Wendell, you'll look up consistently, or you're saying your name consistently. Whereas if you're minimally conscious, you'll do it every once in a while and we'll miss it. And it's a problem because, families will have these people in nursing homes, and the families are spending a lot of time with their loved ones. And they bring the doctor in, who's usually an untrained, not a neurologist or trained in these things, often a geriatrician or an internist or a family practitioner who may not know a whole lot about brain injury, but they're providing medical care to these folks. And they'll say, I saw Johnny look up when I came into the room. And the doctor will be skeptical because he doesn't know a whole lot about this nosology, these diagnostic categories. And then Johnny doesn't do it, just confirming the bias. And then so it's not believed. And there have been tragic cases of people who families have seen behaviors that were consistent with awareness and consciousness that was dismissed for decades.
So when we got somebody in a vegetative state, is there a high probability or a low probability that they will move to this minimally conscious state? I mean, does this happen often, or is this really?
Yeah. So it depends on what kind of vegetative state you're in. If you had traumatic brain injury, you can recover from it probably around 70% of the time. If you've had anoxic brain injury, maybe 50% of the time. But there are time courses that pertain to it. So I was talking about permanent and chronic. So after the 3 months after anoxia and a year after traumatic, it used to be you never got better, right? But now increased data and surveillance suggests that 20% of the time people will emerge out of those brain states, mostly the traumatic brain injury. But if you think about it, if 40% of the people are misdiagnosed with traumatic brain injury, that accounts for a large bit of the variance.
Sure.
But it's also inadequate evaluation. And we also have evidence that, like in my book, Rights Come to Mind, I profile, and I have permission to use her name from her mother, Maggie Worthen. And she was the subject of a study that was published in Science Translational Medicine by Dan Fengon and Nico Schiff, my close colleague, where over, I think it was a 54-month period, we tracked her brain evolving over time. And she had new white matter tracks across the hemispheres and in Broca's area, which is responsible for language. And so there were structural changes in her brain over that time. The problem is, as a public health and a disability rights, issue, we send people to nursing homes. They may yet still be in the vegetative state. They morph into the minimally conscious state. Nobody notices it, and their brains are changing. And there's no surveillance mechanism to go back and check to see if there've been any changes in their responsiveness. And so you have a situation where, again, 4 out of 10 people, remember the play Hamilton, right? In the room where it happens, they're there. People are talking about them. They may be potentially understanding, and no one knows that they're listening. And that kind of, and there's evidence of people who appear behaviorally unresponsive, processing language in based on activations using functional neuroimaging. We don't know what they're understanding, but they're processing, responding to language versus to gibberish.
So before we come back to this responding to language, I just want to get back to the vegetative state and the brain dead, basically. Do we clearly understand the demarcation between those two?
Yeah.
Because
I think so.
This is a central neuroethical issue that I think everybody grasps. We don't want to give inappropriate care or no care at all to people who are in these various states, or misdiagnose what state they're in. So have we reached a point where it's relatively clear who may still show a response pattern that can return to at least a viable form of minimal consciousness, or are we still in a realm of mystery?
Um, you know, I think it's more mysterious to some rather than others. I think I think
No, I
let's
think
just
we're asking you as an expert. We're
right,
not talking
right,
about those who have
right,
relative degrees of ignorance, but those
right,
who have really been looked at this in depth.
right. So I think the clinical criteria for brain death are adequate and serviceable in most cases. And the problem is that they're not always deployed in practice the way that they've been articulated. So basically, a person who is brain dead is what's called whole brain death, which includes the brainstem. So that's the distinction between the clinical exam between a brain dead person and a vegetative person. But it can be quite disturbing. Let me tell you about the Lazarus reflex. Have you heard of the Lazarus reflex?
No,
This
no.
happens occasionally, very rarely. I've seen it once in my career. But a patient who is lying there, is brain dead, and you remove the ventilator, um, and they're no longer, they're not able to breathe, but sometimes they bring their hands up as if in prayer, and that's a cervical reflex that appears to be alive, but it's a spinal reflex. But they're not, but their beat has stopped. They're no longer alive, and they're brain dead because they didn't breathe after being deprived of oxygen, and the carbon dioxide goes up 20 millimeters of mercury, and they don't breathe. When you're drowning, it's not the lack of oxygen that causes you to take that deep breath that makes you drown with the water. It's the elevation of your carbon dioxide, at which point you can no longer resist the reflex, and you have to take a deep breath. And then in that process, people drown because they swallow water. It's not hypoxia, it's hypercapnia, or elevated carbon dioxide. That reflex is gone in brain death because there's no that comes out of the brainstem. Now, there have been some interesting developments in the context of brain death, most notably the Jahai McMath case in California, which was a teenage woman who had a devastating complication from a tonsillectomy, was declared to be brain dead, but it was contested. And one of the great challenges is there are going to be liminal cases where patients, brain death criteria were established by an ad hoc committee chaired by Henry K. Beecher at Harvard in 1968. And if you read it, they invoke Pope Pius, but they don't invoke a whole lot of neuroscience. And there are very few things in medicine today that depends on 1968 technology. So there might be liminal cases where, patients may still have functional activity below the level of our clinical exam. And so I think we need to begin to think about incorporating some functional imaging sometimes in questionable cases. And there are some efforts underway right now to rethink brain death criteria across the globe, which I think is a good thing. But you can also overdo it and get false positives or false negatives, depending on what side of the equation you're on. But here's work that's happening up at Yale, which is fascinating, which I'd love to share. And it's this thing called the BrainX. It's kind of like FedEx for the brain, but it's called BrainX. And these investigators, whose lab I had a chance to visit right before the pandemic, have this fluid, this dialysate fluid, as it were, that can revivify brains and brain cells. And what they've done is they've taken pig brains of decapitated pigs from a slaughterhouse, hooked these pig brains up into this fluid, and they've regenerated electrical activity in those cells. So the question is, are those brains still dead? My answer is yes, because brain death is the death of the entity working as a unit. It may not be individual cell death, which is where you get the confounding with some of the EEGs and other things, but it's really the whole brain death. So I do think you can distinguish brain death from the vegetative state. with skilled clinical examination and the like. But it's obviously a question of great interest. I think this BrainX fluid is not to revitalize brain dead pigs, as it were, but rather to infuse areas in the brain after somebody's had a stroke, tissue that's dying, and try to reanimate selected areas and bring those cells back within the context of an otherwise alive brain.
Let us transition to your research itself, because I think this will be fascinating for our listeners. So you have been working with covertly conscious patients and others, and you've been working with deep brain stimulation and functional imaging. Can you tell us a little bit about what drove your research, what you were trying to discover, and what you did discover?
Yeah, I mean, my research is the product of a rare thing in science, a wonderful collaboration and friendship with a neurologist called Nico Schiff, who was a brilliant neurologist here at Cornell, and about 25 years ago, we bumped into each other in the coffee shop. We had both been students of Fred Plum, who was his mentor. And was the neurologist in the Quinlan case, and in fact was the person with Brian Jeanette who discovered the vegetative state, the persistent vegetative state. And I was editing a column for the Journal of Pain and Symptom Management, where an ethics column, where the plan was somebody would submit a case, and I would line up commentators who would argue pro and con, or pro and pro, or whatever. And there was this case that was submitted about a patient who had advanced cancer, who had been depressed, and the question was, should she get, a lot of morphine, which could suppress her breathing, which was a real issue in those days about the right to die. This is the late 90s. But the more interesting question was, what about the role of antidepressants in somebody who's been depressed, who seems to be in a coma? So, which is still an unsettled question. And so I asked Nico to write a commentary about this. And it's sort of like, patient appears to be unawake, but what's really going on inside their head? Now, fast forward 20, 25 years later, and now we are realizing that people can have covert consciousness in the ICU. And Brian Edlow at Mass General has used fMRI to show that people who appear to be in a coma may actually be aware. And Jan Clausen up at Columbia did a study using EEG, showing that people who appear to be in coma may actually be aware. That is, when they're given a volitional prompt and asked to do something, they do it in their head. And this goes back to work that was first done by Adrian Owen in 2006. And we did some follow-up studies here at Cornell, where you ask a patient who's in a chronic state, like in the minimally conscious state, or somebody you don't really know their brain state. You say, imagine doing something, right? Imagine, and the classic paper was in Science in 2006. Imagine playing tennis. Imagine walking around your house. Imagine disaggregating linguistically similar words like a riverbed creek and a creek in your neck. And when you ask them to volitionally walk, play tennis, they light up their motor strip. When you ask them to walk around their house, they light up their parietal occipital region, which is for spatial navigation. And when you ask them to disaggregate linguistically similar words, they activate the language area. And interestingly, that first paper was called Detecting Awareness in the Vegetative State. The title almost gave me a stroke, no pun intended, because it was so disingenuous. Because the vegetative state was first described by Jeanette, who is a neurosurgeon in Scotland, who came up with the Glasgow Coma and Outcome Scales, and Fred Plum, as a state of wakeful unresponsiveness. Now, if somebody is asked to do something, and on their scan they do something, they light up their motor strip, they're not unresponsive. Right? They're not wakeful and unresponsive. They're responsive. So it seemed like a misattribution to the vegetative state. And I called this in a paper that I wrote in the Hastings Center report right after that, non-behavioral MCS. that these people were liminally conscious, but they were not demonstrating the behavior. And this is an important distinction about covert consciousness, the difference between what you see and what's actually happening, as it were, under the hood. And it's like in genetics, right? You have genotype and phenotype. All those flowers in Mendel's garden that appear to be the same under the genetic hood were different. Some were heterozygote, some were, had two, were homozygote positive, right? But they were different, and in the next generation, their progeny would look different. And so we have this discordance, right, between what you see at the bedside and what's happening in the brain, and that is materially important because prognostically makes a huge difference. It says not everybody who appears vegetative is in fact vegetative, because they may have covert consciousness or what has been described as cognitive motor dissociation.
Do we need brain imaging systems to recognize this? Or
Yeah, you do. And if anybody wants to, any science geeks out there want to read a really great paper that just for its brilliance, it's the Jeanette and Plum paper, just called this. It's about the persistent vegetative state, and they described it as a syndrome without a name. And I did a deep dive and sort of reading it as literature. That's drawing upon my Wesleyan roots that you and I both share, and reading the text. And if you read the text, answering your question, Wendell, Jeanette and Plum says about the vegetative state, it seems wakeful without responsiveness. And Fred Plum was a great writer, a great editor, real good wordsmith, excellent wordsmith. So that word seems gets underlined. And why did he say that? He said that because in 1972, to answer your question, they had no way of knowing that somebody who appeared vegetative truly was vegetative, because they only seemed so. And they were intuiting, without saying, the possibility of covert consciousness, which I think is just so brilliant. And because they knew the limits of what they knew and they didn't know. Like Oliver Wendell Holmes had this, who was the anatomist, the father of the jurist, and was a pragmatist. He said,
I was named after.
Yeah, right. He was senior. And he says the difference between a superior mind and a vulgar mind is precisely that the former knows what it doesn't know, to paraphrase. So when Jeanette and Plum write, it seems wakeful without responsiveness, they knew they couldn't say it is wakeful without response. It just seems so. And that's why we need that neurotechnology. But I want to just digress a little bit to tell you really where this insight came from for me. And I didn't realize this, even when I wrote my book, Rights Come to Mind. It was kind of an unacknowledged debt to Saul Bellow, the Nobel laureate. You know this story about him? He was in a coma, and so I was in the mid 90s. I was very young, and I was at this conference where I went on right after Saul Bellow and Edmund Pellegrino, who is one of the founders of bioethics. And then a 30-something-year-old me, goes on, it's kind of like, going on the Ed Sullivan show after the Beatles or something, how do you follow up that? But Saul Bellow talked about his experience having had scromboid poisoning, which is like histamine poisoning from a bad a Caribbean fish in the Caribbean. And he was medevaced up to Boston, I think Boston University, and was in an ICU. And everybody thought he was in a coma, but he's having these kind of, daydreamy kind of hallucinations and he's aware. And initially he thinks, he was nearly 80 when this happened. So it's rare for an 80-year-old to survive this. It's even rarer that they have a Nobel Prize in literature to tell the tale, right? So he's telling this story about, he's in the ICU. He thinks he wants to die. And then it's flashback to his childhood movie theaters and his beloved Chicago, and all kinds of memories flood in. And then he thinks he wants to die. And then this attractive woman comes to visit him, and at the bedside, who he later in this reverie realizes, well, she seems very nice, and wow, she's my wife. Janice was her name. I don't think I want to die. And so he tells this story. Meanwhile, Janice is at the bedside being very dutiful and playing Handel's water music because he liked that. Anyway, so this talk and hearing his talk immediately preceded by a year or so that case that I described where I ran into Nico Schiff and we're thinking about the inner life of this person with a coma. And after hearing Saul Bellow, I never ever when I was making rounds at the bedside and we're talking about prognosis or whatever, I'd say, okay, guys, everybody, let's take it out, men and women, guys, generic, let's take it out of the room and let's talk about the prognosis in the hallway so the patient can't hear because we don't know what they're hearing. So covert consciousness. And, again, let me just make one last quick point. This is an example where the art was ahead of the science. Saul Bellow described what we would come to understand scientifically 25 years later.
Let me bring a digression in here because you referred to Wendell Holmes Sr.
Yeah.
And for those who don't know Wendell Holmes Sr., you might know him because he wrote the poem Ironside about the battleship, the first battleship really that we had in the Revolutionary War, which is still today can be seen in Boston. It's not in Boston Harbor; it's across the bay. But in any case, he, for all practical purposes, was the man who started the germ theory of medicine. He deduced that childbed fever, which was killing off many women, was being carried by probably doctors from one woman to another. And yet we had absolutely no idea what germs were at that point. And this was even a few years before Semmelweis demands that there is this sterilization process that the physician should be engaged in. And the only reason I was bringing that in is I think there's a parallel here to where we are and what you have been saying about our understanding of brain activity as we can deduce it from these people who are in vegetative states or other states. We're still in a very primitive period in neuroscience in terms of what we understand and what we don't understand, comparable to how little we understood about that even germs existed at that time, but that we were really building from the available observations of some astute physicians, and of course now the availability of some technology that can help us see when a patient is engaged in mental activity around your questions, even though there is no behavioral activity going on at all. So this is still very much a frontier as I'm perceiving it.
Yeah, I mean, when I give, when I'm on the road, I'm giving talks and I'm going through this whole nosology of the vegetative state, minimally conscious, and all that stuff. I have an image on the side of the slide of a Vesalius print of a skeleton contemplating a skull, which is 16th century anatomy, right? And I said, people are going to look at my slide if it were to survive with the same notion of how primitive that is. And I've used this phrase, we have to have what's called nosological humility. Everything, and I'm a pragmatist, my bioethics is Deweyan pragmatism. It's all contingent and it's all evolutionary. And so we have to have humility about what we know. And these categories are getting refined. What's really interesting right now, and it's a little further ahead in psychiatry than it is in disorders of consciousness research, is we're going through a transition between what we observe and mechanism of injury and illness. So in psychiatry, we had the anecdotal psychiatrist who had a gestalt impression of what you had. And then we had the diagnostic statistical manual, which was based on public health data and probabilities. And now we're moving into, which circuit is deranged, that there are subtypes of depression, each of which responds to different kinds of medication, for example. And I think the challenge is making the transition for the DSM to a circuit-based approach, or in neuroscience and neurology, moving from behavioral criteria to criteria based on neuroimaging. And here's the paradox. Not everybody who can do things on a clinical exam in the minimally conscious state can do the same task in a scanner. So the sensitivity and specificity is not there.
Yeah.
So we have to, our metrics are evolving, but the notion of the primitive, we know so much more than when I was a medical student, but I think we're gonna, my students are gonna have advantages that I'll never see. But the key thing, use the key word, was technology. And the thing that has revolutionized this whole era is the neurotechnology. I once wrote an epilogue to this book, called The Handbook of Neuroethics. It's really like an 800-page handbook, Oxford handbook, edited by Judy Illes and Barbara Sahakian. And I was asked to write the epilogue, and I said something to the effect that, if there is such a thing as neuroethics, because I'm not sure it's different than ethics in general, but I'm becoming convinced. I said it's an ethics of technology. It's an ethics made possible by technology, and an ethics whose responses are often technological. And I think this notion of covert consciousness is how technology has brought to us an ethical problem that heretofore we didn't know existed, right? But then neuroimaging is also, and then technology, neurotechnology can be the remedy to that problem, because it gives us a way for these people to communicate. Give you two examples, right? One is, you say to somebody, and again, this is still investigational, you say to the person, imagine playing tennis. If you want to say yes, imagine playing tennis. If you want to say no, imagine walking through your house. So the very technology that reveals the problem now provides a way for the person to get out of their head and communicate. And deep brain stimulation is another, response to people who are in these liminal states of consciousness.
Let's go down that a little bit, because I think we've focused very much on the brain imaging side of this, but we haven't focused at all on your work in deep brain stimulation. And I have a feeling that for many of our listeners, this is Greek when we're talking about deep brain stimulation, but it's actually been going on for a while, and it's being used as a valid clinical treatment for certain diseases. And perhaps you can talk about that a little bit.
Right. So it is being used as a treatment, vetted treatment that it's paid for by CMS for Parkinson's, drug refractory Parkinson's disease, and it's an investigational device intervention for lots of other things, from OCD, which has what's called the humanitarian device exemption. And the work we're doing is using DBS to treat people who have are in the minimally conscious state.
Before we talk about what you're doing with it, what is it? How's it done?
So it's a pacemaker for the brain. Okay, like they're a pacemaker for the heart. And in fact, companies that make pacemakers for the heart also make deep brain stimulators. So what it is, it's basically a wire bilaterally implanted into various parts of the brain, depending on what you're trying to stimulate, and the target would be different. And this wire is hooked up under the skin to a battery pulse generator, which exists in your chest, usually one on each side. And each of these electrodes have 4 contacts, each of which can be, turned on or off, and size of the charge and the frequency. And with all those manipulations, you can have an effect. One of the challenges is that if your charge is too high or the field is too big, you get into an adjoining area, and you could have an adverse effect or a side effect that would be uncomfortable or disquieting to the patient or subject.
It's being used for Parkinson's.
Yeah, so it's a great story. This guy, Alim Benabid, who won the Lasker Prize with Maylong DeLong from Emory for elucidating Parkinson's disease, is a neurosurgeon in France, and he was doing what's called a pallidotomy. They were like the way they used to treat Parkinson's disease, and sometimes they still do, is they will burn a hole in part of the brain with an electrode to decrease certain symptoms. But before they do that, they stimulate the area to be sure they know where they are, the proper area, right? And they can tell based on the sound of the nerves. Each nerve has a different song that they sing. It's really beautiful. And as you're going in, you hear different chirping sounds, and the skilled electrophysiologist can hear, oh, now we know where we are, and to me, it just sounds like bird song. Anyway, so he's stimulating this part of the brain to find out where he's going to ablate or destroy the brain. And he notices the tremor stops. And he has this, epiphany. He says, well, maybe I don't have to destroy brain. Maybe I can stimulate brain instead to have the same effect. And that's, of course, how deep brain stimulation for Parkinson's disease was discovered. And that was around, I think, 1986.
Yeah.
And he wins the Lasker Prize and could well win the Nobel Prize. And he's a lovely man. He's, really humble and smart and very gracious, and still doesn't know. Interestingly, last time I spoke with him, maybe he's figured it out by now, but he doesn't know if the effect of the stimulation is stimulatory or inhibitory.
Interesting.
Because it's a tangled web, and you could inhibit an inhibition or stimulate, a negative or a positive, and so you don't know what you're actually doing. But he did know that it decreased the tremor, and it increased the fluidity of movement. So it all was born with Parkinson's disease, as it were. There were earlier examples of electrical stimulation of the brain, including Delgado and others. But now we have ramifications in other areas for OCD, the obsessive compulsive disorder, which is kind of a tremor of the mind, of thought, right? And that has approval as a humanitarian device exemption, which means it's safe, but efficacy has not been yet proven conclusively. And also in depression, that Bart Nutan for OCD, Helen Mayberg for depression. These are very promising areas of inquiry, and our work has been stimulating the thalamus in the context of deep brain of traumatic brain injury. And we first reported our results in Nature in 2007 in a patient who was in the minimally conscious state, who had been, brutally assaulted, couldn't eat by mouth, couldn't talk, was bedbound, and sometimes, moved his eyes to communication. That was it. With deep brain stimulation bilaterally to the intralaminar nuclei of the thalamus, he was able to say 6 or 7 word sentences, say the first 16 words of the Pledge of Allegiance, tell his mother he loved her, and as I recount in my book, Rights Come to Mind, go to Old Navy and voice a preference for the clothing that he wanted his mother to buy. And it's again, this is still investigational, but it was the first use of deep brain stimulation in the minimally conscious state. And to me, it was, the restoration of agency ex machina, right? A little bit of electricity brought it home. And I'll tell you a story to me, which was like the high point of this. So we were writing the protocol. And I spent 10 years on the ethics of the protocol because, as a ethicist, medical ethicist, you could imagine how difficult this was. We were doing a phase 1 study, right, which is just proof of principle, that it's not toxic, without the hope of benefit in a patient who could not give consent. And it was we're putting electrodes in someone's brain. So, the challenge was, how do we do that without the possibility of consent? So the argument was, my argument was, we were confusing, the provision of consent with respect for persons. So it's one thing to do something to somebody who can consent without their consent or over their objection. It's quite another thing to do something to restore agency, so people can participate in decisions. And so That argument eventually won, and we had approval from the FDA and multiple IRBs to do this intervention. One day,
has that argument gone much beyond, you're making the case for this? I mean, it's a fascinating argument. The restoring
yeah.
agency is a legitimate justification for doing therapeutic interventions without informed consent. I mean, I'm just
Well,
wondering
it's not without informed consent.
that would come up in, or is this so unique in that respect?
Well, it wasn't without consent. It was without the patient's consent or the subject's consent. It was surrogate authorization,
Sure.
surrogate consent. Yeah. But I think it just shows, the confusion about the application of a principle versus the principle itself, right? So generally, informed consent is a good proxy for respect for persons, but it isn't always so. And I had to disaggregate that. And fortunately, it worked out well. If there had been a bad outcome, maybe I wouldn't be on this podcast right now. But what was fascinating was one day we were done with the study, and we were doing post-trial stimulation parameters. And I told you about how each electrode has 4 contacts, and it's very laborious because every time you change something, you got to do all this testing, and it takes hours. And it was a hot summer day, and the subject's name was Greg, and I had permission to use his name. And he was obviously getting tired, and it was the end of the day. And one of the physiatry, PhD of physiatry, says, "Greg, do you want to stop?" And he says, "Yes." And I looked at my watch and I recorded the time. I think it was like 2 o'clock or something. And I recorded it. It's written about in the book. And I said, at that moment, we had given him back agency, not at the level of informed consent and refusal, but dissent and assent. And he was back in the room. He was telling us what he wanted to have done.
Great.
And it was kind of a vindication of sorts, because when we wrote the IRB protocol and we were using surrogate consent, I put in this little codicil that if a patient ever regained capacity, we'd have to reconsent them. He didn't get to that level of consent, but rather, assent and dissent. But it was the restoration of this person through a little bit of electricity.
What a wonderful story that is. Let's transition though a little bit. So these have all been treating therapeutically conditions that of diminishment in one form or another. But you mentioned to me just yesterday, actually, when we were chatting, you mentioned to me that it's possible that this technology might be used for enhancement purposes, not just therapeutic purposes. Can you just tell us a little bit about that?
Right. I mean, first of all, I think it's important, as we had our terminology to start about what are all these different brain states. Sometimes people think this is enhancement, and I think we need to distinguish restoration with enhancement, right? And there's an important distinction. But it's conceivable that one could take a person with normal function and make them function better with one of these devices. But then we get to the point of what we call ethical proportionality, because the burden benefit is, we have to put an electrode in your head, which makes it risky. Is the benefit likely? And I would just say that in 1977, the National Commission that wrote the Belmont Report on the ethical guidelines, the 3 principles, which became 4 principles, they also wrote a report on psychosurgery. And one of the prohibitions was on enhancement. And they said, it's okay to treat pain. It's okay, to treat epilepsy, things like that. But they were against enhancement. And I think it's an important bright line distinction. And I think it violates proportionality. Also, it creates the potential of a super digital divide, as it were, where those who can be enhanced will be enhanced, and those who will fall to the wayside. But I think this is an area where I think the technology could lead to challenges. So the challenge with deep brain stimulation for enhancement, it relates to this, what we call in ethics speak, proportionality, the relationship of burdens to benefits, right? So it's a hypothetical benefit, but a very real burden that we're putting electrodes in someone's brain. And that becomes just what we say, ethically disproportionate. But what's going to change over time, and it's already beginning to change, is non-invasive interventions where the burdens are less. So the proportionality is potentially more favorable, and you might be willing to take a more hypothetical risk. The challenge is that this creates a digital divide, and it also violates the prohibition of the National Commission against enhancement, so I think it's something. I think we should talk mostly about restoration and less about enhancement.
It is interesting that many of my pro-enhancement colleagues want to argue that why, if they aren't willing to take the risk, recognizing that that there may be real dangers for the first people willing to accept invasive enhancement technologies or drugs or whatever they think might be helpful, that they should have the right to give informed consent to do that and take the risk. And I've always argued that that doesn't really solve the problem, because what if something goes wrong? Then who's responsible for you?
Right.
If you are reduced in your capacity. Unless you have an insurance company or policy that's willing to cover that totally, then you actually put the society in the position of having to take the proportional risk, even if you're willing to take the risk yourself.
Right. Informed consent is necessary, but it's not sufficient. And for all the reasons that you articulate. And currently I'm doing, but it's a very interesting question about who gets to make the decision for these things. And currently I'm doing I have a grant with the Brain Initiative, the NIH Brain Initiative, interviewing patients and their families. I use patients, but they're subjects and their families who are participating in a DBS trial for moderate to severe brain injury. These are people who can give their own consent, so they satisfy that criteria. But what's really interesting is these patients had a severe brain injury. Their family members for years have been making decisions for them as they nurse them, as it were, back to health. Now they're in this position where they're in this clinical trial. And there's a kind of a push me, pull me about who gets to make the choice. Legally, ethically, it's the patient's choice. But because it's their brain, it's their body, it's their lives. And there's this very interesting delegation of allowing people to make risky choices because the consequences of the decision is greatest for them. In this study, though, we're very careful about independently establishing the decision-making capacity of the subjects to be able to make that choice. And if they don't have decision-making capacity, they can't participate in this trial. But the relationship between parents and children or spouses, because it's interesting that the patients, and I'm calling them patients, they're subjects, just to disaggregate the confusion, they're more willing to assume what has been described as the dignity of risk because they understand the burden of their lives. Again, they're invoking a kind of proportionality and making a choice that works for them. But I think proportionality can shift. And I think this is an area that requires additional attention. But again, you're taking the risk can't absolve all the others of responsibility. And I as a clinician or as an IRB chair or whatever I'm doing, am implicated in the choice as well. So it's not a unilateral decision. That's why simply looking at informed consent is too limited.
The interesting thing about this is it comes up in a vast array of technologies that might improve our life situation, but might actually create burdens. So even radical life extension has this problem. You may be able to extend the life of the body, but not extend the life of the mind. And then who's responsible for you if you live an extra long life, but you have no capabilities or diminished capabilities? It still then becomes the responsibility of the health community, of your family, of others. And there's still this deep problematic of when the risk has actually been understood in terms of where it is proportional and who will be held responsible if things go awry. This is totally in a different realm, but you're writing a biography of Lewis Thomas, who may be known to many of our listeners as a best-selling author whose Lives of the Cell won the National Book Award.
He was somebody who crossed the science and humanities divide. He wrote poetry in medical school to make some extra money, published in the Atlantic even. And later in life, Franz Ingelfinger, who was one of his senior residents when he was training at Boston City Hospital after graduating from Harvard Medical School, heard him give a lecture and said, why don't you write, this column? You can do whatever you want. We're not going to edit it. We're not going to pay you, but we're not going to edit it. It became Notes of a Biology Watcher. And they were just elegiac, beautiful essays. He was a great admirer of Montaigne, and he mastered the essay form. But he was also a great observer of nature. And one of the things that I think is wonderful about Lewis Thomas, he was also a great scientist and immunologist and administrator. And so understanding the trajectory of his life in a way is understanding the trajectory of mid-century medicine and where it succeeded and where it failed. I think at the end, he had regrets about sort of the divorce between the humanities and the sciences, something I, in my career, have tried to unify in the work that I do. I think bioethics is that kind of, convergence. But I think at a certain point in your life, you run out of mentors and you have to look to great historical figures for guidance. So I see this as a form of self-therapy. And I love reading his stuff and I love going through his papers and I'm just getting into it. So it's early on, but I think, scientists love to be in the lab. Historians love to be in an archive. And I think I've got a little bit of each. And so I hope that, I'll live long enough and this podcast will survive long enough to come back and celebrate the publication of a book, but it's going to be a long time from now.
Well, I could be wrong, but I think that future practitioners, as neuroscience develops further, are going to look back to you as a mentor and an inspiration.
Thank you.
Well, thank you ever so much, Joe. This was truly wonderful, and we're always appreciative of your sharing your time, your insights, and your expertise with us. I hope this has been a rich and thought-provoking discussion for you, our listeners. Thank you for tuning in, and a special thanks to the team at the Carnegie Council for hosting and producing this podcast. For the latest content on ethics and international affairs, be sure to follow us on social media at Carnegie Council. My name is Wendell Wallach, and I truly hope we earn the privilege of your time.